And good morning, I'm Dr. Deuk with my team here at Deuk Spine. On May 16, 2023, we're broadcasting live spine surgery. Our patient is here from California, and she's come to Florida for the Deuk laser disc repair, and she is, she has an injury to her spine that has caused several disc herniations. If you look at the, going to give you a little bit of numbing medicine. If you look at the MRI, you can see in the bottom corner, she has more than one disc herniation. She's actually got 5 of them. And really, all 5 are not causing problems for her. It's only, I believe, only 4 out of the 5 are causing problems. So we're going to fix the bottom 4 that are causing symptoms. The top one is bad looking, but it's not, in my opinion, not causing. That's the L1-2. I don't believe it's causing any symptoms. She has no pain there. She has no radiculopathy. So at L1-2, her radiculopathy is lower. Her radicular symptoms in her leg are on the right side, so we're coming in on the right side. Her back pain is in the L2, 3, 3, 4, 4, 5, 5, 1 region. All right, we're going to get started. Now, if you have questions, feel free to ask me during the surgery. Sean? Not bad, huh? I just eyeballed that one, and we're pretty close. The hardest disc to get to, by the way, is the L5-S1. We've talked about that before. You could see her L5-S1 even has a listhesis. Henry, this is a good one for listhesis. Can you
Copy
hear me,
that.
Henry?
Yes,
Yeah.
copy that.
So, Sean, so maybe tomorrow when we see her, Sean,
Mm.
you know what I'm saying? We can mention it and you can pull it in.
Yeah, I can do that. No problem.
Because so many people ask about spondylolisthesis, anterolisthesis. Folks, take a look at that x-ray right there. Can you show them the lateral, Henry? You can see the L5 slipping on the S1 and the L4. Show the back. Look at the back of the vertebrae. Follow the back of the vertebrae. That's how you figure it out. Show the back of the vertebrae. Show the back of 5. Start at the top, go to the bottom. And if you follow this line of the arrow, it should line up with the back of S1, but it doesn't. It's too far forward. So that means it's slipping. And then look at 4, 5. Follow the back of 4 down, and it lands somewhere in the disc space. It doesn't land at the back of the L5. So show us where it should line up to. Right there, right. So that's about a centimeter of slippage, okay? Give us the AP. All right, I probably could be a little bit more medial, so I'm going to redirect. Stay where you are. Shot. That's better, lateral. So you can see where the needle is. It's in the foramen at L5-S1 on the right side. She has a little bit of scoliosis. Show us the slight amount of scoliosis she has. So folks, this is a great case, and Henry, this is a great case to highlight scoliosis as well as listhesis. The Deuk laser disc repair is not going to fix either the listhesis or the scoliosis because they don't need to be fixed. Her problem is pain. Is she reliable? Well, we're well below the nerve root. Okay, we have accessed L5-S1, which is the hardest transforaminal disc to access. We're now going to go for L4-5. We're going to work our way up. Now we'll see how many of these we can get with one incision. The incision is 7 millimeters. It's tiny. And I probably will do a little bit bigger than 7 on her, just because if I do a few millimeters bigger, if I take it up to 10 millimeters, which is still tiny, by the way, you can see how small it is, then I might be able to get all 4 discs with one incision. I'm going to try for that. All right, next is L4-5. Shot. Beautiful. One thing about the Deuk laser disc repair you're watching, endoscopic surgery, is that it's virtually bloodless surgery compared to a fusion, which if you've ever seen a fusion done, they lose a lot of blood. Shot. That's why they keep you in the hospital, because they're losing so much blood, AP. We have a lot of patients on our Facebook group that talk about going for fusions, and I try to discourage them and say, don't do a fusion. It's completely unnecessary. It's barbaric. The surgeon is literally going to rip your spine apart and fuse bones together that shouldn't be fused. They're supposed to move. Your spine is full of joints that are supposed to move. And the pain people get that requires a fusion, it always comes from the disc, about 90% of the time. And it comes from other joints called facet joints, the other 10%. Now, what you're seeing right here is we're fixing the disc. We're going to fix her discs without fusing and without opening her up. We're just going to do it through a tiny incision. I have a feeling we're going to get all 4 with 1 incision. This is great news for her. She's going to look great in a bikini. Not have to worry about a big scar on her back. All right, shot. Wow, pretty cool, huh? Now, what allows me to do all 4 discs with 1 incision is her. It's her anatomy. It's not me. It's really how those discs line up. And if you notice, they all kind of project back to the same point. Okay, shot? And that point is where the skin entry point is, obviously. Remember, I set that point when I did the L5-S1. She doing all right? Yeah. Shot? All right, we're going to need her AP reliable soon. Any questions you have during this broadcast, feel free to type them up. I'll answer them for you. Our patient is awake. We do need her awake in the beginning to help me navigate through the foramen, as well as to answer some questions about whether she's having pain. That's good. Show us the needle there. You guys see how the needles come from the side, right? Now, most spine surgery is done straight through the back, right there. And guess what you hit when you go there? You're going to hit those bones. Show us the bones they're going to hit. They're called lamina. All those bones back there. And when you hit them, you can't get to the disc without removing them. So the surgeon's first thing he has to do, or she has to do, is to literally rip all those bones in the back of the spine out so they can get to the disc. And we've been doing that for 100 years. And it's been okay because, hey, we had no other way to do it, right? Take a look at this. That would be the incision we'd be making on her from here, right here, all the way to here, if we were doing this surgery open, like a fusion. Okay, and if we were doing artificial discs, it'd be on the other side, and it'd be really bad. She can't have artificial disc, by the way, because she has slippage of the bones. Are you comfy?
You okay? Okay, we're gonna ask you some questions, all right?
Yeah.
Are you comfortable?
But see, this is virtually
Yes.
bloodless surgery, folks. If you don't want to lose your blood during spine surgery, and by the way, there are surgeons who will lose liters of your blood, like liters. If you don't want to lose liters of blood during spine surgery, this is the perfect surgery for you. Minimally invasive, bloodless, scar tissue-less, laminectomy-less, and basically painless. Her entire surgery will be done without her taking any narcotic painkillers home with her. Okay, the only thing she'll take is Tylenol and a muscle relaxer. All right, this is the last of the 4 discs. You can see we've lost maybe 10 drops of blood. That's half of a milliliter. So the average surgery of spine surgery fusion is going to lose about 500 to 1,000 milliliters. We will lose 1 milliliter, virtually 1 milliliter the whole surgery. That's our average. All right, did you do an AP? Let's get an AP. So remember, we're using 2 views, front, back, side to side on the X-ray machine. This is a fluoro machine. Perfect. Doesn't get any better than that. Stay there for a second. Folks, we have literally the most highest quality fluoro machine in the world that you can buy. It's a Siemens. Show us the psoas muscle. You can actually see the muscle on this x-ray, right? Show us the lateral border of the psoas. It's right there. You guys see that shadow there? That's a muscle. It runs inside the pelvis, in the back of the spine, basically in the back of the pelvis, right along the side of the spine. Now, a lot of spine surgery fusions are being done from the side. Show us the coming from the side. And the surgeons are going through the psoas muscle. This is like the X-lift procedure, the O-lift procedure, the D-lift procedure. And when they go through the muscle, they actually are damaging the nerves that are in the muscle. And that's why people are having weak legs and they can't walk after surgeries like that. Okay? Our goal is to not damage any of those muscles. All right. Let's go ahead and show the audience, why do people have back pain? Where is it coming from?
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right. For those of you who were watching our video, you can see shot as I'm navigating into the L5-S1 now on the opposite side, which is the left side. I'm encountering some bone here, but you can see from our video that the back pain people have comes from the disc, and it's not the whole disc that hurts, it's a part in the back of the disc that hurts. It's called the annular tear. Yeah, see that? I need to be a little higher. And that annular tear is small. It's literally the size of a pea, the area causing people's back pain. And we go in endoscopically and we can fix that area the size of a pea. Stay away. We can fix that area the size of a pea with a laser. We do it endoscopically, arthroscopically. Just stay away for a second. All right. All right, so we're gonna have to, I've numbed up this area over here. I have to get into L5-S1, and her hip bone is high, which is the problem that a lot of surgeons have with L5-S1. And it's really hard to get into in some patients because of that high hip bone. Sean? All right. I'm making some progress. Shot. That's not bad. Getting there. Shot. Are you comfy, AP? So we need her awake for the beginning of the surgery to help me. Help me navigate safely through the foramen, but also I need some answers from her in a few minutes. So I'm still too lateral with that left side. I'm gonna have to maybe start more medial. Shot. Shot. Sean? I'm trying to place the last needle on the left side at L5-S1. Is she reliable?
Hello. Hi. You okay? She said yes.
You're doing great.
She's doing
She's
good.
awake.
Reliable, yes.
So I just need to navigate. I'm still more lateral than I want to be. So I think I need to just start a little more medial. She's a tough one on the left side at 5'1", because her spine is actually quite narrow. Wow, honestly. Sean? All right, AP. That looks good on the lateral view. The needles are lined up almost perfectly. You can see that. Show us 5'1", the needles lining up, and then take the picture afterwards. Now we're putting 2 needles in at 5'1". 5'1" is the L5-S1 disc. Yeah, and the 2 needles are almost perfectly lined up there. So let's take an AP and see where we are. Remember, if you're gonna, that's really good. If you're gonna do this kind of surgery, you must use 2 views, 2 planes. We call them planes. One is shooting that way, front, back, or AP. The other one is shooting sideways. Some surgeons use more than 2 planes. They'll actually use an oblique plane. You okay? Where do you feel that?
Feel that in your back? She said in the back.
Okay, yeah, that's perfect. We're there. So you can see, show us the 2 needles. One more picture, it's a little blurry. All right, there you go. 2 needles in L5-S1. And show us the listhesis. For those of you watching, spondylolisthesis at L5-S1, grade 1. Spondylolisthesis at L4-5, grade 1. Retrolisthesis at 3-4, about 5 millimeters. Retrolisthesis at 2-3. So she's got spondylo and retrolisthesis both. The bottom 2 vertebrae are slipping forward, the top 2 are slipping back. Okay, any questions from the audience?
No current questions.
Great, so far everything is going perfect for this lady. Her surgery is going great. We've lost 1 cc of blood. That's 20 drops of blood, the whole surgery. And we're pretty much done losing blood, okay? Now, when I first met her, I heard her story. And I know she had an injury to her back. And after that injury, she started having back pain. She hoped that it would go away on its own, but it didn't. Like many people, they think that the pain in their back's going to go away, but it doesn't. Okay, because it's coming from a tear in the back disc, and every time you get active and do anything, you're going to aggravate that tear and make it worse. It just starts hurting again from inflammation, which I showed you. So people start changing their life. They just start becoming sedentary. They don't do anything. They sit on the couch, watch TV. They sit on their phones. They don't go out and enjoy life physically. They don't be active. And they've modified their behavior so they don't aggravate their back pain. And they think their back is healing, but it's not. They're just basically reducing the symptoms because they're not active anymore. But if you want to be active, you're going to keep aggravating it, so you fix it. The Deuk laser disc repair you're watching is the first surgery in the world that addresses the source of back pain directly, fixing it with a laser rather than fusing and metal and artificial discs and procedures that don't work. Now she has 4 damaged discs, L5-S1, and L4-5, L3-4. I'm not left-handed, by the way, I'm right-handed, but I'm writing left-handed. L4-5. So that's why my writing is so bad right now. Please don't fault me for it. All right. Now, I know that she has a tear. I can see it on the MRI in each of these discs. Okay? And these things are, tears are allowing a herniation, which is pinching her nerves. Are you comfortable?
How are you doing? She's doing well, yeah.
All right. Any pain?
You have any pain?
No?
No.
How bad is that on a scale of 1 to 10?
Give us the numbers. 0.
10. Is that where you typically get your back pain? That was you guys see that on the x-ray? That was L3-4, 10 over 10?
Yes, we do.
10 out of 10, and it was concordant. Concordant, folks, means that's her typical pain every day. So we found one of the painful discs. You guys see it? Show us on the x-ray. All right, there's the needle, there's the dye, it's the dark stuff. Look how it leaked out the back. Show us the tear in the back of the disc, right there. It all leaked out when I injected it, and it went up the spine, okay? Is it better now? Yes. Okay, I'm sorry about that. Have you watched these surgeries from California?
She watched 10 videos.
10 surgeries, okay. Are you comfortable? All right. How bad is that on a scale of 1 to 10? Show us the tear. How high does it go?
10.
10. Is that where you typically get your back pain? 10 over 10, and it's concordant. I'm sorry. We're almost done, I promise you. You're doing great. All right, show us the tear on that L4-5 disc that we just injected. It's 10 over 10. There it is. And the dye leaking out the back. You can see the herniation. You got it. Show us where the nerve is. The nerve is going to be, that's too far back. A little forward, right there. That's where the nerve is. And it circle it, make a little circle. Yep, and look where the herniation is compared to the nerve. It's literally right next to the nerve. So that inflammation is getting on the nerve. That's why people get pain down their legs, inflammation. So much misinformation out there we want to clear up. All right, are you comfy? Yes. All right, that's L2-3. That's L5-S1, that's L5-S1. You comfy? Yes. Any pain? No. How bad is that on a scale of 1 to 10?
10.
10, all right. Is that where you get your back pain? All right, we got another 10 out of 10 at L5-S1, and it's concordant, okay? So we're mapping out her pain right now. People ask me, Dr. Deuk, does Deuk Spine map out pain? Of course we do. The only way you as a surgeon or doctor can cure a patient's back pain is to know exactly where it's coming from. And if you don't know exactly where it's coming from, then you're guessing. And if you're guessing, do you want a doctor who's guessing where your pain's coming from, operating on you or treating you with invasive procedures? I wouldn't. So that was okay for 100 years. We just give narcotics, we give shots, we do surgery that didn't work because we didn't know where the pain was coming from. All that has changed. It changed here at Deuk Spine Institute. We're the first in the world to identify where back pain comes from every single time. Now, the truth is not everybody comes to us with, 10 different causes of back pain, but some people have 10. Let's count hers. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. She actually had trochanteric bursitis too. So she had 11 causes of back pain. Each one requires a very specific treatment at each of those 11 spots. You can see we're fixing 5 of them right now. Are you comfortable? We're going to put you to sleep in a minute, all right? Then when you wake up, all that pain will be gone forever. You excited about that? What'd she say? You're welcome. It's my pleasure. That's why we're here.
Take good care of you.
All right. I'm sorry.
We're already doing it. Last one here.
Last one. How bad is that on a scale of 1 to 10?
10.
10. All right. Is that where you get your back pain? Yes? All right. Well, we found all the spots, and when you wake up, your pain is all going to be gone. Isn't that beautiful? All right. Folks, Henry, let's show the video as to how does this laser surgery we do work to get rid of pain coming from a damaged disc.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, welcome back. You've seen now exactly how a herniated disc does cause pain in the back. A lot of doctors will tell you that herniated discs cannot be fixed because they don't know how to fix them. A lot of doctors will tell you to go see pain management for your herniated disc, but they can't help you. Pain management can't fix a herniated disc, folks. Wow. I mean, that is a big tear. I mean, it's just going in so easy. Yeah. And what happens in the system today is patients are sent off to pain management by their doctors, and the pain management docs cannot fix you. I promise you that, 1,000%. They'll put a stimulator in you, they'll put a pump in you, but they cannot actually fix your problem. Yeah, that's good. And you'll just keep coming back to them, and you'll spend $100,000 in your lifetime paying for pain management treatments that never fix your problem. So, folks, you are witnessing history. Those days are gone. We can now source your pain very specifically, and we have a curative treatment for every single cause of back pain and neck pain. The problem is there's so many joints in the spine that could be painful, but the good news is we can fix all of them. All right, any questions from our audience while we get started with our first disc, L5-S1, on the right side?
No current questions.
Great. Well, in that case, without further ado, I'll just keep teaching. All right, we're going to go down the rabbit hole into the L5-S1 disc. And there it is. Automatically, you can see right away that the disc is damaged. The blue dye is staining abnormal nucleus pulposus, which is herniation. And there's scar tissue, there's calcium, there's inflammatory tissue. You guys see the pink stuff right there? That is the cause of her back pain right there from L5-S1. It's called inflammatory tissue. And inflammatory tissue is always pink. It doesn't need any special stain to see. You can always see it. As a matter of fact, you can see it on your face when you have pimples. What color are your pimples? They're red. They're pink. They're pink because of the increased blood supply. What you're seeing are red blood cells. Why is the light so low? I feel like we could turn it up one notch. Let's just try that. I feel like it's too dark. Maybe you can. That's better. Let's just leave that. All right. So inflammatory tissue is the painful tissue. I need help here. And patients that have painful discs have inflammation coming from the disc. We saw the video. We'll play it again. And that inflammation is the cause of their pain. We've all had a painful zit on our face, right? So you all know that what causes that zit to be painful? Well, it's little nerves in the skin around the hair follicle that's infected. And it's actually bacteria that causes the inflammation. This is not bacteria in the disc. That's your pimples are bacteria, but what causes the inflammation in the disc is actually the herniation. the nucleus pulposus. The nucleus pulposus is the source of inflammation because the nucleus is like a bacteria in the sense that it can elicit an inflammatory response. Elicit means to provoke, to make, to create, to initiate, to cause to happen. So what causes the inflammation in the disc, in the tear of the disc, in the annular tear, is the nucleus pulposus. It's what we call pro-inflammatory, right? We all know what pro means. Pro means for. It's pro-inflammatory. That nuclear material stuck in the annular tear is pro-inflammatory. We have a nice new animation I'm working on. We're going to release it soon, probably in the next 3 to 6 months with our new website, which by the way, I had to fire our web developer because he was not doing his job. And we had to find a new web developer. So it's put our entire website, the new one, really far back in production. So anyway, but when we do release the new website, you're going to see a nice animation explaining how the annular tear and herniation cause inflammation. We actually have that now. We just showed it to you, but we have a new one coming that you might also enjoy watching. All right, what we're seeing here is herniation and tear. This is the cause of her pain right here. I'm literally zapping it away with the laser. Now people ask me, why can't you just use the metal tools to do all this? The metal tools don't work. They don't remove this stuff. A lot of this is scar tissue right there. You see that, how tough it is? I could put the metal tools in there. They cannot grab it and bring it out. A lot of spine surgeons will tell you, you don't need a laser. And that's only, they tell you that only because they've never used the laser. They have no idea what it's capable of doing. That's like saying you don't need an oven to cook. You can actually cook with a campfire, your dinner. But, I mean, who wants to cook their dinner with a campfire, right? I mean, sure, sometimes it's nice to go out and make a campfire and cook dinner, right? But practically speaking, from an efficiency standpoint, from a quality and consistency standpoint, using a campfire to cook dinner is not something people are doing on a regular basis. We're all using an oven. So the laser is like an oven to spine surgery. It's a new technology that for some people, most of us, it's been around for years. It's just some people are slow to adapt and adopt. It's called adapt and adopt, right?
That's classic in modern day medicine.
Modern day medicine, like Dr. Berndes is saying, it's classic, you know? I mean,
very regimented, they don't change their training.
Yeah, it's very regimented, they don't change their training. And honestly, I can understand why the training would be so regimented and so, concrete. They don't want to change what works, right? So if you do a laminectomy on someone's back and it works 50% of the time to give you 50% relief, then if that's the best treatment you've ever seen, then you stick with it, right?
Because you don't really know better and you're satisfied with that percentage.
That's right, because you don't know better and you're satisfied with that percentage. Because it could be worse. Could be worse with other procedures. So doctors and training institutions kind of stick to the old ways of doing things. It's taken fusions and artificial discs many years to actually come around and become more popular. So the laser surgery is the same way. Just nowadays, I'm really seeing a lot of fusions being done on the spine. Now, when I was trained, that was the newer way of doing it with instrumentation. And now everybody's doing fusions with instrumentation. But I was trained 25 years ago, and basically, I have good news. Things have changed again. They've gotten better. And that's what the laser surgery is all about. Any questions, Henry?
No current questions, but we do have a comment from Stacy on YouTube.
Stacy, welcome.
They said, like watching your videos, hoping to get insurance and and get you to do my neck. I have C4-5 herniation. I live in South Carolina.
Wonderful, Stacy. Thanks for joining our broadcast. We'd love to help you. We like helping anybody that wants to be helped with us. We do have a lot of patients from the Carolinas. As a matter of fact, oh, look at that herniation right there. Pretty cool. Let's get that one out. Now see, something like that I can probably reach in because it's loose. I mean, it's still stuck down a little bit, but not enough that I couldn't grab it out, I think. So I'm going to try to grab that out because lasering that's going to take forever. And forever is not good for the patient. You want to keep surgery, you know, as they say, short and sweet. You want to just keep the patient asleep for the bare minimum amount of time you need to. So anything that can increase the efficiency of surgery is going to be better for the patient as long as it doesn't compromise results, right?
Better wake-ups.
Uh-huh. So anesthesia is one of those things, surgery is one of those things that you really want to try to minimize the amount of time the patient's asleep for. Laser. Just about done on this disc. Another few, maybe another minute, and then we'll be done. And we're going to move to the next disc. You can see the nerve root there. Actually, you can see the bottom where below the nerve root, I should say, just below it. The nerve root is actually hidden behind that metal, which is good. That's what we want. You don't want the nerve root exposed. There's the nerve root's right up in there, in that fat. Now I'm going to get a little more of this. This is the top of the herniation, the top of the tear. It's always hard to get at 5-1 because of the angle you're coming in, but this is a little bit more scar tissue and herniation just below the nerve root. The nerve root is literally up in that fat right there. So it's still protected. It's right up in that fat. But that's the herniation and we're done. We've cleaned it out nicely. You can see the end plate. I'm happy with that result.
Lights on, please.
Again, L5-S1, that's the hardest one to get to. We got to it on both sides. So we're done here. I'm going to suck the tube out. Next, since we're finished, we're going to give a little betadine. Betadine is a topical compound that basically kills any kind of bacteria or protozoans. I think viruses as well. Hey, I don't have any suction here, guys. Come on.
Sucker.
Yeah, that's fine. But I do need it when we're done. Irrigation. So I'm going to irrigate the betadine out. The betadine works instantaneously. If you've ever worked with betadine and you've got a microscope and you can look at the bacteria or protozoan, they literally die as soon as they make contact with betadine, instantaneously. It's not even after a while. They die immediately. I've studied it in a petri dish, and as soon as literally as soon as the iodine touches them, they're dead. So it's kind of cool. Good for the patient, obviously. We don't want any bacteria. There's not going to be any bacteria, but every surgeon I know irrigates their wound when they're done. And the reason we do that, we're trained to do that, is just in case something happened to get in there, a drop of sweat or a piece of foreign material just dropped and it's carrying a bacteria, then this way you saturate the area and cleanse it before you get out of there and finish up. We've never had an infection with the Deuk laser disc repair. We've been doing this surgery 16 years. We've not had a single infection. So how's that for spine surgery without an infection? That's one of the worst complications you can get from spine surgery, infection, okay? And the chance of an infection is very high with fusions, artificial disc, laminectomy, discectomy. The risk of infection goes up the bigger the surgery is, the bigger the incision is, and whether you put in foreign body like metal, screws, rods, cages, all of that, artificial discs, all those things increase the chance of infections after surgery dramatically. but we've never had a single infection with the Deuk laser disc repair. I've actually treated patients with infections that they got elsewhere. We had a patient with a microdiscectomy done in Virginia at the Virginia Spine Institute, and he came here afterwards to get his infection treated with the Deuk laser disc repair. And the way we did that was I went in with the laser and I cleaned out the infection in his disc, and I put in antibiotics while I was in there, and that cured his infection. Sean?
I remember that, she did really well.
Oh yeah. All right. Any questions?
Yes, this next question comes from Sheila on Facebook.
On Facebook.
Yes.
Hi Sheila, welcome to our live stream.
They ask, when people ask me how your laser technique differs from others, I just say it's about 99% effective. Can you explain in more detail how your laser differs from others?
I can. I don't know anyone else that does laser surgery on the spine like we do. And the problem, Sheila, is that these other doctors that supposedly do laser surgery, they don't. They just use the word laser, but they don't actually use a laser in their surgery. They use laser because they want to capture our success from our patients. And we have a lot of copycats out there in the world now saying they do laser spine surgery, but they don't do what we do, okay? And when you ask me how it differs, well, there's lots of ways it can differ, right? If I bring a laser in the operating room and wave it around in the air for 5 seconds, that's definitely different than me. If I bring a laser in the operating room and wave it around for 10 seconds, that's also different. So you get my point, is that what they're doing with the laser, they don't do anything like what we do. They don't know how to. They don't have the right equipment. They don't have the right training. This technique was developed at Duke Spine. It's only done by us, to my knowledge. And our results, you hit the nail on the head, Sheila. What matters is the results in the end. Nothing else matters. If you like Metallica, nothing else matters. What matters is the patient's results. Did we cure the pain at that area we're treating? And the Deuk laser disc repair is the only laser surgery that does. No other laser surgery does. So when you ask me how does the Deuk laser disc repair differ from other laser surgeries, what are the other laser surgeries doing? You got to tell me, because they don't broadcast their surgeries like we do. They're not showing you what they're doing. But what I'm telling you is, all I know is that these other doctors that say they do laser surgery don't really do laser surgery. So until you show me a surgery done elsewhere, a laser surgery done elsewhere where they actually use the laser, show me some video of it, and I'll tell you how it's different. Because right now, as far as I'm concerned, they're all lying to you, the public, saying they do laser surgery when they don't. Okay? For example, Laser Spine Institute. Everyone knew Laser Spine Institute. They were the #1 laser spine institute in the world, if you don't mind me saying. They had 4 locations all over the United States in the 4 corners. And they got into business in 2004, and they went out of business in 2019. Okay? And they used to say Laser Spine Institute, laser spine surgery, right? But I have friends that work there, and they told me that they never used the laser, ever. They just had it in the name. So that's typically what doctors will do, is they'll tell you they do laser spine surgery, but they don't. They don't act, what's that?
Bait and switch.
It's called a bait and switch. Bait and switch. They tell you they have something, and then when you get there, they say, oh, we're out of it. You need to do something else. We see this all the time. We hear about it all the time from patients that have gone elsewhere.
I had it happen with my roof.
Yeah, it's called the bait and switch, folks. I mean, I know I'm not teaching you anything new here, but I'll give you an example. There's a spine surgeon locally here in this area. By the way, you see the pink tissue? You guys see the pink tissue? That's inflammation tissue right there. I can't focus on it, but
We can see it.
Yeah, you can kind of see it there, right?
A little bit, yeah.
Yeah. Anyway, that's where the pain comes from, because that pink tissue is inflammation. Inflammation hurts. If you've ever had a zit on your face, that's inflammation. You know it hurts. Anyway, we have a doctor here in this area, not at Deuk Spine, of course, we would never do this, but they do bait and switch all the time. They tell the patient they're going to do laser surgery, and then the patients get there on the day of their surgery, and they tell them in the pre-op area, waiting to go back, oh, your insurance won't improve your laser surgery, so we got to do a different surgery, like a fusion. Unbelievable. Right now they're being sued by patients. But this happens all over the place, folks. If you want me to comment on someone else's laser surgery of the spine, get me video of that surgery, and I will tell you how our surgery is different. But don't just ask me how these scammers who say they do laser surgery don't actually do it. Don't ask me how their surgery is different, because they're not using the laser to begin with. They're not doing anything we're doing. And you're not going to get results. In the end, who cares what they do? You know, who cares if they have a black mamba in the operating room and they use black mamba venom? As long as it cures your pain. I mean, honestly, as long as it's safe and it's effective. That's what matters. Those two magical words, safe, effective, and there's one more, it's called durable, meaning it lasts. That's what you as a patient want. Safe, effective, durable. 3 magical words, I guess. Okay? And the Deuk laser disc repair is the safest spine surgery available in the world. It is the most effective, and it is the most durable. We've actually looked at our patients that had this surgery done, 6 years average follow-up on the group. And they had 92% of their back pain gone, 92% of their leg pain gone. That was after 6 years of follow-up, on average, 6 years. So there were some that were 8 years, some that were 10 years. It's just a mixture of patients that had this done on their back. So what matters is results, people. Stop getting so concerned about the names and this and that. You know, safety, effectiveness, recovery, and durability. That's what you want to ask about. Okay? By the way, there's no way to do this surgery without the laser. So I get patients asking me, can you do the surgery without the laser? I say no, absolutely not. You can see why. Grabbers don't work. And I'll tell you why grabbers don't work, okay? If you really want to know. These are so long because they have to fit down the tube that when you go to squeeze the handle, they're so skinny that you can't really get much pressure. You know what I mean? You can't really grab it that hard. If you've ever gone to a theme park, like Universal Studios, they sell those little plastic dinosaur heads that bite. You know, you get it for the kids, and they're in the car and they're biting each other with it. They can't really rip through the skin with it because you can't squeeze hard enough. The plastic starts to bend, and you can't really get a good firm hold. Well, it's the same thing. Metal actually bends too. And these metal instruments we have, they don't bite forcefully enough, right? It's not like an alligator biting with all those muscles. Because you can't transmit the force effectively down the tube to that tiny little instrument because they're so small. Just to give you an idea of how small they are, you guys see the laser fiber right there? That's 1 millimeter, 1 mm, 1 millimeter. And the grabbers are not much bigger, right? They're about 3 millimeters. So if the grabbers are only 3 millimeters, that's so small and tiny, you can't get enough force to do the surgery. That's why you have to use radio frequency or laser. And I know some doctors, a lot of doctors use radio frequency because it's cheaper for them. I use laser because it's better, much better than radio frequency. Radio frequency doesn't work. By the way, that orange stuff is calcium deposits, little calcium. And that's not normal. You should not see calcium in a disc, okay? It's a sign of chronic inflammation happening inside the disc. That scar tissue right there that I'm touching, There's some granulation tissue, inflammatory tissue. There's a bone spur right now. Okay, so we're in here fixing this disc quite nicely. Just about done here. Yep, thank you. Great questions, by the way, from the audience. I appreciate you all asking.
We have another question.
Yeah, just give me a second. Yep. All right. I'll take the questions.
This next one comes from Samir on YouTube.
Hello, Samir.
They ask, "Hi, Dr. Deuk. Do you treat annular tears?"
Yes, Samir, we do. That's what we're doing right now, Samir. We are treating an annular tear. This is called an annular debridement. It was first described by Deuk Spine Institute, described by Deuk Spine. We're the first ones to publish it. And now there's been a few other doctors who are now starting to treat the annular tears. Okay, but this is where all the pain comes from. Great question. Let's go ahead and run the video. Since this is a long surgery, Henry, let's run that video again showing how does an annular tear, herniated disc, cause pain in the back and down the leg.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. And we just literally saw the nerve root while you guys were watching the video. It was white. If you go back, you can watch it in the corner, the white thing. I was touching it with the laser, but not turning the laser on, obviously, just touching it, which doesn't harm it at all. But you can see the nerve root looks good at the end of the surgery. No issues there. I put in the betadine, put in a lot of betadine. But we're just irrigating. Probably one more irrigation. All right, if you have questions, I'll be happy to take them. You have a pipe cleaner? Once you clean that. Great, that's nice and clear. I need it now. It's supposed to be cleaned here. And if you couldn't do it in time, just give it back. All right? Yeah, thank you, I see it. Okay, we're done with 2 discs, right? That's 2? Yep. 2 down, 3 more to go. For those of you who want to see what the scope looks like, this is it right here. It has a scope, a camera. I use Richard Wolf, and I think they make the best scopes. All right, we're taking the tube out. So far we fixed all of these discs with one little cut, just about 10 millimeters 10 millimeters. It's a Band-Aid incision. I'll put a stitch at the end. Luis, I'll put a stitch at the end. Since it's such a big incision. All right, any questions from the audience?
Yes, we have a comment and a question. This comment comes from Canes25 on YouTube.
Hi there, Kane25. Nice to hear from you today.
They said, when it's all said and done, your procedure will go down in history as the greatest advancement in spine surgery ever, sir.
Hey, I appreciate that. Dr. Bernda says he agrees. I think so too, and I appreciate you saying that. You know, maybe you're right. I think you're right. And I only say that because so many people have back pain. You know, I'm not curing cancer. I would love to cure cancer. I don't know if it's in the cards for me in life, but you know, if God's will, then I will. But right now, this is what God has planned. And honestly, when I reflect on it, I've reflected on it for many years. The fact that we can now cure back and neck pain that's plagued people and all these, basically it's just part of our culture to believe that back and neck pain is something you have to live with the rest of your life. But it's so pervasive and so common that I think because it's so common, that makes this a big advancement. You know what I mean? Like if it wasn't so common, if it was obscure and rare, then it wouldn't be, it's an advancement, but it really doesn't affect that many people. But because of the number of people that will be affected with this treatment and their lives improved, I truly believe that this will be a significant advancement in medicine. But unfortunately, I'm up against, you know, what we call the spinal industrial complex, which is a bunch of people getting very, very wealthy off of putting metal in patients and harming those patients. And it's so ingrained in the teaching now of spine surgeons, orthopedic and neurosurgeons to do fusions and metal procedures that I don't know how we're going to get out of that rabbit hole. Wait, the dilator's coming back a little, so I'm going to advance it. There's some pressure in this disc. If you notice, the dilator was kind of pushing back as we were going in. That's because this disc is more inflamed and there's more pressure. So I really appreciate that. I feel the same way because of the sheer number of people suffering with back and neck pain, and doctors can't fix them. There's really no other cure for them. They're just treating their pain, you know, and the people are suffering with that pain and getting treatments that don't fix them over and over and over, and more invasive, more invasive, more invasive. And honestly, there's so much greed now among the doctors who are driving all this. It really angers me to talk about it, because I feel doctors should be looking after the best interests of their patients. But I know these doctors, I've talked to them, and a lot of them are extremely greedy. They just want the money, and they go into pain management because the patients never get cured, and they keep coming back, and they realize that it's like, what do you call it, job security, but that's not how you should be thinking about your patient. You should be thinking about your patient as somebody who you want to fix so they don't come back. And that's how we do it at Deuk Spine, but unfortunately that's not how it is in the world of spine pain. Spine pain has attracted some very bad doctors and some very bad, what do you call it, companies, you know, and they're very powerful, you know, and they all collude together to keep prices high and to keep people in pain, and it's horrible. And I'm like one person against this. It's not even David versus Goliath, you know what I mean? Like, I truly believe that story in the Bible about that the smallest and seemingly weakest, insignificant person can actually do something great in life against evil. And you just have to be committed to the principle of sacrificing whatever it takes to win against evil. And that's what we're dealing with, and I am committed. I've been committed for years. We've been broadcasting for 10 years now, trying to raise awareness of what's happening in spine and educate people about the truth. And it's been a long and arduous road, and I feel like we're very close to having a breakthrough. But we really need Elon Musk to come and help, or Bill Gates, you know, somebody with money and power and influence, because we're just a small company. If you saw where we are, we're literally out of a 20,000 square foot building here in Florida, in some corner of the world. So, yeah, it's been challenging, but I agree with you. This is, in my opinion, because of the sheer number of people's lives that will be improved, this is the most significant advancement in spine surgery that we have seen in history. Of course, we all stand on the shoulders of giants, and I really mean that. You know, I couldn't have done it without everything that I've learned from my teachers and from reading and from other scientists and doctors publishing information and data. It's been a collective effort. It's not all mine, of course. I just happen to be, I guess you could say, the key, right, that fit into the door, that opened the lock. But the key is made from metal, and metal is mined from the earth and shaped and formed by other great people. And it's been a collaborative, collective effort. And to me, the most important people are my team right here. You know, like Luis, Berndes, all my nurses, all my team, Jordan, Oscar, everybody. There's too many people to name, and then of course my patients who believe in what we're doing, you know, and believe in a better way for themselves and their families and their lives. So it's been quite a journey, and we're not done by any means, of course. I have some really good news. I haven't mentioned it. I was going to talk about it later, but we finally received some payments, good payments from Blue Cross Blue Shield of Florida for the laser surgery. And, you know, I don't know if they're coming around finally, but it's probably too early to say that. But we still plan on obviously pursuing it until we get this accepted by all the insurances, not just Blue Cross, not just Cigna, not United, but every one of them. And the thing about it is I truly, truly believe 100%, I know this is going to happen. When these insurance companies finally come around to the Deuk laser disc repair and cover it 100% of the time, what you're going to see is a massive, massive, massive decrease in spine surgeries being done, and the money that will be saved will be in the order of tens of billions and billions of dollars, not even tens, hundreds of billions of dollars every year. Because this is so minimally invasive, no complications if it's done properly, and people don't really need much treatment afterwards unless they have some facet pain or SI pain or piriformis pain, which again can be treated. But basically it's a paradigm shift, and I truly believe that the insurance companies will save hundreds of billions of dollars collectively every year if they just adopted this as the best treatment and saved fusions and things like that for very rare cases when it would be needed, which is very, 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 very rare. So anyway, I see the writing on the wall. It's kind of like the person who discovered the computer, first developed the computer, or first discovered the camera or a phone. You know what the future holds because it's a technology that people have to have. And it's just a matter of time before it's completely adopted and disseminated everywhere, and everyone's doing it. And what I believe is going to drive that change are people, patients, not doctors. I don't think doctors are going to drive it. I don't think the big rich companies that make so much money from doing fusions, they're not going to drive it. It's going to be driven by the consumer, the patient, who demands a better service, a better outcome than what they're getting right now, which they're getting just garbage right now. So, from other doctors. We need a catalyst, though. We need somebody or something to catalyze. You know, I'm a biochemist by training, and a catalyst is something that is used in a chemical reaction where change is occurring, and a catalyst doesn't make something happen, It just makes it happen faster. So catalysts basically promote and accelerate reactions that are going to happen, but you can take a reaction that may take a year to happen, and a catalyst will speed it up and make it happen in 5 minutes or sooner. So what we need is a catalyst, and I am not a catalyst. I don't have the money, the connections, the influence to be a catalyst. Somebody like I said, Elon Musk, Bill Gates, somebody who cares, has the resources available, they can catalyze the change that needs to happen. But it's obvious to me it will happen. It's just a matter of time. There's the tear, for those of you wondering. You can see the annulus to the right, the white stuff. That's normal. Then to the left there's some, but it's torn right against the end plate. And there, the blue stuff in the middle is the herniation. And it's literally the nucleus, the jelly from the center, stuck in the tear, preventing it from healing. Preventing it from healing. That's it. That's the crux of the issue. And your body is constantly attacking that nucleus herniation, trying to get rid of it so that the disc will heal. Your body wants to heal. Everybody's body wants to heal. But sometimes you cannot heal, and you need medical help to heal. Well, whether it's an antibiotic, whether it's a debridement surgery, that's why we call this a debridement, an annular debridement, because the body needs help to heal, and it cannot do it on its own. We all know about diabetics, people with arterial disease, smokers. They have these wounds, these ulcers that don't heal on their legs, right? And they have to have them debrided surgically. Well, that's exactly what we have here. We have this material stuck in the tear, this nucleus, blue stuff right here, and it literally is keeping this disc from healing itself. And in that process of the disc trying to heal, it's painful. If you've ever talked to somebody with a diabetic ulcer, a vascular ulcer, it hurts. They're painful. Arterial insufficiency ulcers hurt. Now, venous ulcers don't, because they're so engorged the nerves aren't working. But when you have an arterial ulcer, they hurt. They're painful. And they have to be surgically debrided, and the tissue has to be revascularized. So there's a surgical treatment for those, and there's a surgical treatment for this. And that's what I used. I drew upon my experience as a surgeon, upon my training, my education in medical school and residency, and I said, it's not inconceivable that we have a situation where the body is trying to heal this thing and it can't, because I've seen that before with leg ulcers in people with arterial disease. So anyway, I just put 2 and 2 together, and I came up with this technology, and that's why we're here doing this, because it actually works. All right, just about done. Almost done with this one. Then we'll move on to the last disc on this side, and we'll finish up with the other side, one disc, 5-1. Look at that herniation. That's just stuck in the tear right there. I got to get rid of it so the disc will heal. Pretty straightforward. Not rocket science.
We have a couple questions.
Sure.
This next one comes from Oz on YouTube.
Hello, Oz. Welcome to our broadcast again. We have some regulars here.
They ask, can someone have a 1 millimeter disc bulge that causes nerve impingement?
Yeah, great question, Oz. Can someone have a 1 millimeter disc bulge, which, by the way, all bulging discs are herniated discs, that causes nerve impingement? So, Oz, I'm going to answer the question for you. It's not an easy answer. It's tough, okay? The answer is yes, you can. And here's how. When you're doing your MRI to diagnose your 1 millimeter disc bulge, you're laying down. You're not putting any weight or pressure on your spine. So if there is a bulge, it could be bulging back at that moment. So it's not really sticking out that far. But then you get up and you move around, you put weight on the disc, and guess what? It bulges out like to 6, 7, 8 millimeters. So yes, you can. The other thing to think about is something called congenital stenosis. So if you're born with a narrow spine already, then that 1 millimeter bulge that bulges out to 5 millimeters is actually going to hit your nerve, whereas it doesn't hit other people's nerves because they have a bigger spinal canal. So if you have spinal stenosis you're born with, called congenital spinal stenosis, and on top of that you have an acquired deficit or deficiency like an annular tear that would allow the herniation to come out with weight bearing, then yes, you can absolutely get nerve impingement. But I'll tell you this, if your symptoms are pain down your leg, it's not nerve impingement causing it. It's inflammation. And all you need is an annular tear to do that. So yes, it's totally fixable. We can fix it at Deuk Spine. And get rid of those symptoms permanently. All right, just about done. And I'm just cleaning up the lateral herniation here. Do you notice I go back and forth? I'm looking medial, then I'm looking lateral. If you're going to do this kind of surgery as a surgeon, I recommend you do both. When I started out doing these years ago, I didn't know to look laterally. Nobody really told me. And, you know, when you enter the tear, some of these herniations are really big, and they actually extend laterally too. So you got to make sure you get it all. And this is all lateral herniation, meaning it's going off to the side of the disc rather than medial, where most herniations are. This is a lateral herniation. Not so common, but they do happen, and if you miss it, then the patient's going to have problems possibly. Not always, but one of my patients I did surgery on, she asked me, I watched your surgery and you told me in the surgery you said that you only got 50% of my herniation. Is that a problem? And I said no. I mean, we never get 100%. The worst we do is 50, and 50 is actually good. If you're gardening and you remove 50% of your weeds out of your garden, that's really good, right? Nobody gets 100%. It's not possible anatomically to get 100%. It's physically impossible. And it's physically impossible to kill all the weeds in your garden. All right, I'll tell you why. Because if you're plucking them, you're looking for them, the ones that are above ground, right? You still haven't gotten all the babies that are too small to see, okay? And the reality is that nothing in life is 100%. I know my wife loves me, but I know she doesn't love me 100%. I guess I could settle for 90% and be happy, right? But she's not happy with me 100% of the time, that's for sure. I know how to get her upset, and she knows how to get me upset. All right, we're done here. You can see a vein right there, pretty cool. Just take a look at the fat for a moment. Every one of those little glistening little stars, little sparkles, that's one fat cell. And that right there is a vein. And you can see the blood literally coursing through that vein. That vein is called Batson's plexus, and it's carrying blood from the spine areas back up to the brain.
Slides on, please.
It's pretty cool. I just love anatomy. If you want to be a surgeon, you have to love anatomy. At first, I didn't like it. You know, my first time I took it was at USC Medical School. My teacher was Dr. Snow, and those students that were really serious about anatomy, well, they're the ones who want to become surgeons. So you literally had to go not just to anatomy class, you had to go to the lab, dissect dead people, and then you had to go for extra time. Like when the professor, Dr. Snow, was down there, you had to go there and people would ask questions and he would show things on the body. He was a cool guy. I love Dr. Snow. And they called the people that hung out around him whenever he showed up in the anatomy lab. Everybody would like leave their cadavers and sweep over to him, and they called those people snowflakes. Snowflakes. You like that? Anyway, I'll tell you a funny story, not so funny, at USC. I love USC, great med school, Los Angeles. They had a problem with the class after my class. The next year, they were bringing some of the donors, you know, people that donate their body for research and medicine so the medical students can learn. They were bringing a couple of donors through, potential donors, obviously. They were still alive, trying to decide if they should donate their body to the medical school. Well, they came into the lab just as the students were studying for exams, and they had boxes of pizza everywhere around the dead bodies. They were playing football in there, you know, running touchdowns and passes, and I mean, it was bad. So they put the whole donor program on hold for like a couple of years, and until they fixed it up, and the students got in trouble, obviously. But that's something I just remember about anatomy. Anatomy was tough. In medical school, the professors are always trying to trick the students on exams because they want to see who really understands the problem, or who understands and studies the hardest and learns the most. They want to separate the wheat from the chaff. So they always try to make the test very tricky. Is that it right there? Yeah. Especially gross anatomy, histology, pathology. Our pharmacology teacher, Dr. Berman, he was one of the nicest professors I've ever had. My God, what a man. I mean, he was like a dinosaur when I took his class. I'm sure he's not alive anymore. But he had taught that class for so many years, pharmacology, that he had it down to like a perfected science. He had the best notes, and he was the nicest man, nicest professor. And he didn't have to be tough. You just study his notes and you learn the pharmacology. Some of these teachers, they try to, they give you filibuster, you know, they give you all this information they're never going to test you on, and they know it, and they try to obscure what they're actually going to test you on. All right. Filibuster. And so you can, if you don't learn everything, you're not going to do well on the test. Pull it, the guide wire. So basically, you have to learn all the nonsense that they're not going to test you on, plus the actual stuff they're going to test you on to do well. But Berman was very straightforward. I mean, literally, he had every single like type of receptor, drug, how they worked. You know what I mean? And it was very simple. He didn't complicate it. All right, let's see what we got there. Shot? Okay, so we're entering the L2-3. We fixed all the other discs on the right side except for this one. Shot? This is the last one on the right side. Shot? And then we're going to head over to the left side and fix the L5-S1 because she needed bilateral 5-1. Any questions?
Yes, we have a question from Oz once more on YouTube.
Mm-hmm.
They ask, can inflammation from the annular tear be permanent, or at some point does it dissipate completely on its own?
Yeah, great question, Oz. So can inflammation happening in the annular tear, is it permanent or is it go away on its own? The answer is it's permanent. Unless you have this surgery or unless you fuse the disc with a cage and clean out the whole disc, and then you get lucky and you get that stuff in the back. That's the only way it's not permanent. Okay? The reality is, Oz, that these herniations just keep happening. So every time things settle down a little bit with the inflammation, that person then goes out and plays sports or helps their roommate move some furniture, and then next thing you know, they're pushing out more herniation through the tear because the tear never heals. Okay, so that's why the inflammation never stops, because the tear never heals. And they keep making more herniations. Every time you reherniate, you get more inflammation. Sets it off again, another few months. Until eventually, in some people, they just get constant pain. It never goes away. Because that means they have a lot of herniation, usually, and it's not going away. That's where we come in with the laser and we zap it away. We're basically just helping their body heal right here. That's what we do. We are helping your body heal by removing the source of inflammation and pain. And by the way, this patient, we will cure her pain. I guarantee it. Okay, she's going to come in tomorrow after surgery. By the way, this is outpatient surgery. For those of you who don't know that, we do these every week. These patients go home an hour after surgery. In her case, of course, she'll go to a hotel. Like most of our patients, they stay at hotels. And she is going to come back tomorrow, and I hope she does a nice testimonial so you can see. But what I'm trying to say to you is her pain will be gone. And we will not fix her scoliosis. We will not fix her spondylolisthesis. We will not get rid of a degenerative disc. It's still going to be there. Everything you guys see on your reports that you think needs to be fixed, it doesn't. The only thing that needs to be fixed is the annular tear. And if you have a pinched nerve, you know, if the nerve's being crushed by the herniation, you got to fix that. It's called a decompression. Most of the time, the nerve symptoms come from inflammation, not compression. There's a piece of herniation there. I've gotten it freed up enough that I could probably grab it out. Yep. Just a small piece. Most of the pieces of herniation float out. There you go. There's your tear right there. You guys see the tear? There's the annulus on the right coming over to, it used to hold hands with the annulus on the left. Yeah, Shiza. I just popped off the little valve. So the annulus on the left there used to attach to the annulus on the right. But then some trauma happened in this person's life. You know, this person had an accident that caused it, but that caused the tear right here, and then it caused the jelly to squeeze out. You can actually see the calcium. You see the little white spots there, right? It's kind of hard to see. I'll try to get rid of some of this so you can see it. You see the little white spots there? Those are calcium deposits inside the tear. That's an indication of chronic inflammation. Inflammation that's been going on for years. Okay? When people ask me, can you age the herniation? I can, actually. And like I said before, herniations are not a one-time event. Usually they're a multi-time event. But I can tell how old the herniation is by being in here and looking at it. All right, what other questions do we have? This is the L2-3, by the way. It was a 10 out of 10 pain. And for those of you who joined us late, we're inside the disc, inside, with a scope and a camera. We have a little television crew here with me. I'm the actual news reporter and the surgeon here. And we're inside the disc that's causing her pain. The L2-3 on the right side. And I'm using the laser, which, by the way, that glass thing there is 1 millimeter. Just give you an idea of the scale. 1 millimeter. And the inside of the tube, that metal tube you're looking at right there, that's around 5.2 millimeters. So you can fit about 5 of these laser fibers in here from side to side. Questions?
This next question comes from Seriously on YouTube. They asked, Doctor, are you willing to do a demonstration of your DLDR procedure operation in a European country to show and demonstrate and guide a European spine surgeon?
Am I willing to demonstrate the surgery in Europe with a spine surgeon to show and guide them? Yes, I am.
Yeah, on how to repair a disc herniation and bulge and thus cure.
Yes, I am. I'm willing to teach other surgeons as long as I believe that surgeon will do a good job with patients. I would want to vet the surgeon to make sure they're high quality, right? That's like asking Messi if he's going to teach somebody how to play soccer. Well, you want to make sure that that person you're teaching has the ability to do a good job, right? Otherwise, there's no point. You'd be wasting your time. So I want to make sure that the person I train is a good surgeon, high quality, good results, good outcome, good understanding of the anatomy, is able to manage complications should they have one. Because I haven't had a complication, it doesn't mean other people won't. I'm a very, very, very well-trained surgeon. I have a tremendous amount of experience. Before I started doing laser surgery, I was doing open back surgeries, fusions, artificial discs, laminectomies, microdiscectomies, everything. And I do it all outpatient. So I'm a very good surgeon normally, and I only want to train doctors that will be very good surgeons. Ones that care about the patient, put the patient first, champions for the patient, somebody who is truly has the right philosophy in life. Not arrogant, not conceited, someone who's open-minded, willing to learn. It's a very, very tall order to fill, by the way. But absolutely, I'd be willing to train another surgeon who I believed in. And just so you, and what's that? And of course the anesthesia too. But truly, seriously, the best way to do that is to bring the surgeon here, because there's so much that needs to be taught that it's hard to do in just one visit to Europe. You understand? So I can go to Europe and I will introduce them to this, but they will not learn enough in one visit to be able to do the surgery. It's not a weekend course. This is a journey that really requires months to learn. We call it a fellowship in the States. So to answer your question, would I go and teach? Yes. But would I expect that doctor to know how to do the surgery? No. Would I condone them doing the surgery after a visit for a few days? No, I would not. Would I support them doing the surgery after a few days of training? No, I would not. So if they want to start doing these surgeries, then they would have to prove that they're committed to this, the practice of doing this right, because it's more than just a surgery. This is an entire philosophical change from what other surgeons are doing. And it centers around making the right diagnosis and providing the right treatment. So yes, I'm interested in teaching, but only to the right person who's committed to doing it. And that's a tall order. And that's why there's not too many doctors doing these surgeries, because it really takes a long-term commitment of learning to learn everything new. There's a piece of herniation. Just about done here at L2-3. You could see the damage to the L2-3 was substantial. It wasn't just a tiny little thing, right? But if you look at the MRI, maybe it doesn't look so bad, but when you get inside the disc, you see just how much damage there really is. We're almost done. Great question so far.
We have another question.
Uh-huh.
This comes from Seriously once more on YouTube.
Yes.
They ask, how deep inside the disc are you right now, doctor?
Hey, that's a great question, seriously. Okay, so take a look. The disc ends right here. This is the end of the disc right there. And how deep are we? Well, if you remember that the width of that glass is 1 millimeter, we're probably 10 millimeters maximum into the disc. Maybe at most 20 millimeters in the lumbar, which, by the way, the annulus fibrosis is around 20 millimeters, okay, thick. So we are as thick as the annular tear. That's how deep we are. We could go much deeper, but we don't need to, because if we go too deep, then we're going to be inside the disc, and we don't want to mess with the disc. We just want to clean the tear, get rid of the herniation here, and we're done. Remember, we're not going to make this a normal disc. We cannot. Nobody can. This is a damaged disc. It'll be damaged for the rest of the patient's life. But we want to make it functional. We want to give it performance without pain. Performance without pain. Functionality. Okay? That's our goal. And we can achieve that goal. It's a reasonable goal to achieve. This is the end of the disc right here. We're just outside. You see those fibers? Those are what's called the ligamentum flavum. And when the ligamentum flavum comes to the foramen, it looks like that. It's called the yellow ligament. It becomes the foraminal ligament. Just about done here. Just, you can see the fat. Now we're outside the disc, way outside the disc, just in the foramen, just underneath the nerve root. So I'm just cleaning up any extra foraminal herniation or scar tissue, anything that would press or irritate the nerve root. That's just outside the disc, on the outside part of the disc, okay? And I'm looking laterally, like I told you. There's still some tear there, some inflammatory tissue. So look at that herniation stuck in the tear. I gotta get rid of some of that, okay? So this will heal too. Just about done. And we're gonna go and do the left side at 5-1, and we'll be done with the discs. Then we're gonna do our new Deuk plasma rhizotomy. All right, done. Take. All right, let's take a look, see if we can see the nerve. Well, the nerve is going to be up there. Actually, I want to clean a little bit more of that. Just below the nerve is that still some herniation there. So I don't want this causing problems. That's why I always look, by the way. As a surgeon, you always want to look before you leave. Oh, I like that. Look before you leave. Haha, a new saying. Not look before you leap, look before you leave. Brilliant. Done. All right. Scope is out, scope off. A little betadine. See? We have this down to a science, folks. We've done so many. It's just like checking groceries out at the grocery counter. We have a system that works. We need to clean that because I think they're pipe it. Where's your guide wire? Yeah, it's nice and clean. It's too late now. You should have that ready to go. Okay. You got to use your brain. I can't be the only one using brain around here. Any other questions?
Yes.
Should I come over there? I'm going to come over there.
This next question comes
Wait, before you come in, before we take the question, I want to show you folks what we've done here. We have fixed 4 discs with that tiny, bring me a ruler. One little cut on the right side, okay? One little cut. There it is. 1 centimeter, like I told you, 10 millimeters. Band-Aid. No blood loss. We had 1 cc, 20 drops of blood. That's it. This patient will go home an hour after surgery. In her case, a hotel. We do this for everybody. It's amazing. The recovery is so fast. There's no laying in bed and writhing in pain on a morphine pump like fusions patients do. You know, waiting around in bed all day, getting blood clots in their legs, going to their lungs and killing them. You don't hear about those. They happen all the time, folks. Dead serious. The biggest reason to do this surgery is not about that it works and it's effective. The biggest reason to do the surgery is that you don't have a complication. Who wants to go have spine surgery and get out of back pain and die? Nobody, right? Nobody does, but it happens, and the less it happens, the better. Okay, and this surgery is very safe. This is your lowest chance of having that type of a complication: blood clots, heart attack, pneumonia. Why do people get pneumonia, by the way, after spine surgery? Anybody know? I know.
It has to do 2 things: body positioning, and then lack of movement after the surgery, and the fact that they're in prolonged ventilation while
Yeah.
in the prone position. So there's 3 major reasons why you get pneumonia after spine surgery.
Sean, Dr. Berndes is saying it. He's saying it's positioning, laying prone on your belly for hours and hours. Okay, and then ventilation issues, right?
That's mechanical ventilation.
Mechanical ventilation.
Lack of movement and being able to take a deep breath.
Yeah.
It's called splinting.
Yeah, lack of movement after surgery, being able to take a deep breath because it hurts.
Morphine contributes to that, and pain contributes to that.
And then, of course, fluid overload is a big one. And I've seen the anesthesiologist during fusions give fluid overload, and my patient developed pneumonia. And guess what? That happened at the hospital. And it wasn't an anesthesiologist, it was a nurse anesthetist, and it happened a lot. I was getting pneumonia in my fusion patients at the hospital. This was like 12 years ago, and I said, what is going on? So I talked to a friend of mine who was an anesthesiologist, and I said, why is this happening? Why are my patients getting pneumonia? And he said, they're fluid overloaded. They're giving too much fluid. Their lungs are filled with water, and they're getting bacteria, and it's growing.
It's like the water out in a spare tire.
Absolutely. And it all happened when the anesthesiology group at the hospital left because the hospital wasn't willing to pay their stipend anymore. Yeah, they weren't making enough money, which is true. They're not making enough money because Medicare pays $80 an hour for anesthesiologists, which is not enough. I don't know any anesthesiologist that works for $80 an hour. That's all Medicare will pay. So what Medicare is saying is, if you hospital, you want to do surgery and make money on surgeries, you have to pay the anesthesiologist. Because anesthesiologists can't survive on $80 an hour.
Well, there's a lot of overhead involved in that too.
Nobody should get it. I mean, anesthesiologists, $80 an hour is ridiculous. I don't know any that will work for that little. So the hospital said, go away, anesthesiologists, come in, nurse anesthetist, and then everything went to shit. And I said, I cannot be part of this anymore. Because for me, if I'm trying to help somebody get out of pain and I'm giving them pneumonia instead, that's not acceptable to me. Yeah, done. You know, that's not okay. But a lot of doctors think it's okay. You know, it's a complication. It's not my fault. It's a complication. It's okay. I still get my paycheck for putting the screws and rods in at the hospital, but the patient's dying or having a complication, and they just write it off. And for me, I feel responsible. I brought the patient to the hospital. I subjected them to that anesthesiologist. A lot of doctors write it off and say, it's not my fault, that's the anesthesiologist, that's the nurse anesthetist. I don't have any control over that.
Based on the nature of your profession, you should always be with an anesthesiologist.
Me personally, I will never go with a nurse anesthetist. I never have, I never will. I'm sorry. Nurse anesthetist, I'm just sorry. Nothing against you. You have a role in medicine, I know, but not in my surgery center. Not with my patients. You know, maybe if I was popping pimples, it'd be okay, you know. Maybe if I was, you know what I mean? If I was doing a 5-minute skin procedure, I wouldn't mind it. But for a complicated spine surgery and prone, it's not, yeah, I'll make a lot more money having a nurse anesthetist because I won't have to pay an anesthesiologist. But that money is dirty money to me. It's dirty. It would not sit well on my conscience.
Nowadays, their pay is equating to our pay, so they're approaching the same pay as us.
Really?
Yeah.
Scammers, man. They're all scammers. The whole system is a scam bot. I mean, the whole purpose of giving nurses the ability to do anesthesia was to save money. And now you're telling me their pay is almost the same as a medical doctor anesthetist? It's ridiculous. They just scammed, you know. They said, oh, we'll save money. But then here they are, in my opinion, doing much worse quality care, not doing the patient any service. And by the way, a lot of these patients that go to the hospital now, and they end up with a nurse anesthetist, they have a supervising anesthesiologist as well. So they actually have 2 bills to pay. So they're paying more than they would have paid had they just had the anesthesiologist. Yeah, our system is completely broken, obviously. You don't save money by reducing quality. You save money by finding efficiency. There's a herniation, by the way. That big thing right there, not this, but the one next to it. Right there is a herniation. I can't get it because it's so big. I'm going to have to pull the tube back a little more. Whoops, this goddamn thing. All right, we'll take the question, Henry.
This next question comes from Trust on YouTube once more.
Trust.
And they ask, can herniated disc in the neck affect blood flow to the brain, and or what are the symptoms of cervical herniated disc?
Great question, Trust. I love it. Can a herniated disc in the neck affect blood flow to the brain? The answer is no, it cannot ever affect. There's inflammation, by the way. It cannot ever affect blood flow to the brain. What are the symptoms of a disc herniation in the neck? Okay, the number one symptom is pain. See the herniation, guys? Look at that thing. I'm going to try to grab it out. So the number one symptom of a herniation in the neck is neck pain. The number 2 symptom is arm symptoms, like symptoms down your arm, pain down the arm, weakness, numbness, tingling. It's coming out in pieces. The number 3 symptom is is headache, pain shooting up the back of your head, to the back of your head, like we call an occipital headache or cervicogenic headache. And then another symptom would be, I already said, numbness, tingling, weakness in the arms, hands, and then cervical brachial pain, which is where you have pain radiating from the neck into the shoulder. And then you have myelopathy sometimes, which is where the spinal cord is getting affected, and then you lose balance. You start having trouble with walking, and you can actually start peeing on yourself, incontinence, urgency of urine. This is a big herniation, by the way. I'm going to try to cut it, lop it off. So myelopathy, and then clumsiness of your hands, clumsiness, buttoning things, tying things, just using your fingers, get clumsy. So those are your symptoms of a herniation. Nice job. Almost done here, guys and gals. This is our last disc out of 5 spots, and we're just about finished. I'm gonna finish here in a moment, and then I'm gonna do the Deuk plasma rhizotomy. For those of you who have not seen it done, it is a treatment for facet joint pain, and we've had a lot of very good success with it, getting rid of the pain permanently in the facet joints. It's better than an RFA. RFA is not very effective in most people after trying it for a few times. So the DPR is much more effective, and we're going to be doing that on her right L3-4-4-5-5-1 facets, where she has pain and tenderness, and then we'll be done. So I'm going to finish this disc. Look at all that, by the way. What a beautiful colors we've got, right? We've got inflammation, which is pink. We've got scar tissue, white. We've got some serious calcium deposits, which are kind of yellowish. We've got herniation, which is blue. You know, it's degenerated nucleus. We've got, I already said scar tissue. There's a piece of herniation down there I still have to get. But it's so pretty. It's like a rainbow. All right, Henry. What other questions do we have?
Next question comes from Ferdisho on YouTube. Forgive me if I'm pronouncing that wrong.
Hi.
And they ask how close of the spinal cord you can shoot the laser without hitting it and make a big mess.
Hey, great question. So how close to the spinal cord can you shoot the laser without hitting it? All right. So this is a question I get all the time. You see the laser? Okay, it's off right now. Do you see it removing the herniation? No. Let me bring it here. Do you see it? I'm going to turn it on. Is it removing the herniation? Nope. Now we're about 1 millimeter away. Is it doing it? No. But when I get closer, within 0.5 millimeters, now look at it. There it is. So the laser only works 0.5 millimeters, half a millimeter. Okay? Just to give you reference, the glass is 1 millimeter wide. So half of that width is how far the laser shoots. So it's very safe. All these doctors, folks, that don't do laser, they want you to believe the laser's dangerous because they don't want you to go and get this surgery done. They want you to have their fusion. Please tell me you're not that gullible. All these surgeons that talk about laser being useless, bad, whatever, anything negative, they don't know. They never used it. There's the herniation. Oh, almost had it. They're just trying to keep you from, they don't want to lose business. That's like saying, okay, let's see. Now, I've got $1 million to spend on a car. I can buy a Hugo, or I can buy a Ferrari. The guy selling the Ferrari wants $1 million, and the guy selling the Hugo wants $1 million. What are you going to buy? The guy on the Hugo, he's going to tell you, don't buy the Ferrari. because the Ferrari will break down on you. Well, so will the Hugo. Right? The Ferrari requires maintenance. Well, so will the Hugo. Right? So they're just trying to convince you to avoid something they don't have for you because they want to make money on you. That's all they care about is their money. They don't care about your safety, your well-being. And that's what makes me so angry with these other doctors. They're lying to try to basically not help you, the patient, but to take your money. So if you want to go believe them, go believe them. You know? That's your choice. All right, just about done. One more minute, and then I'm going to be done with this L5-S1. Now, I will give those doctors one thing. There's a lot of scamming doctors out there. There's ones that scam you and tell you they do laser when they don't, and there's one that scam you and tell you don't do laser because it doesn't work. I agree that there's a lot of scammingness going on, and that's what you need to be aware of, okay? But at Deuk Spine Institute, we don't scam people. We fix people with the laser. You can see the whole surgery is done with a laser. We don't just say laser spine surgery and don't use it. We use it every single surgery that we use laser. We use it the whole surgery. It's not just part, not for 5 minutes, 1 minute. It's the whole surgery. And there's a reason we use the laser, folks. It's because it really works. I know it's hard to believe sometimes, but it really... Yeah, we don't park it in the corner. We use it. We use it. And it's, by the way, I can't do the surgery without it. If you came to me and said, Dr. Deuk, I want you to do the Deuk laser disc repair without the laser, I would say we can't. It's not possible. We cannot do what we're doing right now without it. You would have a much worse surgery. Your results would be unpredictable. Unpredictable. I don't like unpredictable. As a surgeon, I don't like unpredictable. For those of you who know me well, I'm a creature of habit. Why? Because I like predictable. I don't invest in the stock market. Why? Because I like predictable. I can't stand unpredictable. It's weird, but that's just my personality. I am not about taking risks for anybody, not me, not my family, not my patients. I'm all about predictability. I want to know what's going to work, and that's what I want to do. I don't want to do things that don't work. Fucking hell. All right, grab her. I don't know. Give me a minute. What other questions do we have?
Next, this question comes from Teak once more on YouTube.
Hi there.
Teak asks, Dr. Deuk, with this procedure, it now seems to be second nature for you. As a surgeon, do you still feel challenged? If so, what are some of those challenges?
I honestly could not hear that whole question. I'm sorry, honey. Could you repeat it?
This comes from Teak on YouTube once more, and they ask, Dr. Deuk, with this procedure, it now seems to be second nature for you. As a surgeon, do you still feel challenged? If so, what are some of those challenges?
Oh, Teak, great question. Well, I'll be honest with you. The surgery itself is mildly challenging, like technically, so let's talk about challenge. There's intellectual challenge, and there's technical challenge, right? They're two different things. And technically challenging, I do get challenged once in a while, you know, but not really that much. And then intellectually challenging, I do, you know, I love teaching, and I guess that's the hardest part intellectually, but sometimes I have like a slip bones, they're slip forward, and it's very hard to get the needle in, you know. That's the hardest part, is the beginning of the surgery. That's where I get the most technical challenge and intellectual challenge as well. So You know, that's what we choose to do, Teak. As surgeons, we choose a path in medicine where, no, I'm not ready for that. I need to take the liquid out first. We choose a path where that fits our personality, okay? And I always encourage young doctors to choose something that they enjoy. You know, what would they find enjoyable in medicine? And honestly, I could never have told you I'd be here when I was a medical student. When I was an undergrad at UC San Diego, I did not know that I would be a doctor. I wanted to be an anthropologist for a while. Here, take this. I wanted to study history and societies and how they adapted evolutionarily over time. It was very fascinating to me, but I'll be honest with you, I have an allergy to being poor. And honestly, the truth is that there's not much you can do as an anthropologist, sociologist. Sure, it's an interesting work, but you're not going to change the world that much, I don't think. Maybe I'm wrong. I could eat my words, but the truth is that I just didn't see that my work in that field would really add up to anything great. And I'm what? Dallegra? I don't know what that is. Oh, Allegra. Dallegra. So I honestly, I like bringing about significant change. And I just thought that I needed to do something that I could actually make a difference in people's lives. And that was medicine, you know. So I eventually went into medical school, and I just thought, okay, I'll be a doctor, a general practitioner. And then I saw surgery for the first time, you know, happening, orthopedic surgery, and I thought, wow, that's so cool. That is really interesting, like cutting people and doing things in their body to fix them. And so I decided I'd be an orthopedic surgeon, not knowing anything about orthopedic surgery, obviously, but just it looked good, it looked cool. I was an athlete, and athletes typically become orthopedic surgeons. I don't know if you know that, but a lot of athletes become orthopedic surgeons. And so I kind of gravitated to that, and then really I went and watched some orthopedic surgery, and I remember thinking, gosh, that's boring compared to neurosurgery. So then I ended up becoming a neurosurgeon, thinking I was going to basically cure people with spinal cord injuries, and be able to walk again. And I had ideas about doing it using basically a computer brain interface that you could think to move your arm. And at the time, nobody had ever thought of that, but I was just a resident, and that's where I was interested in. Let's just go over this. This is a right 3-4-4-5-5-1, correct? Correct. Everyone agrees? And the right side is here. Shot? Yeah, there we go. Better. So I ended up choosing neurosurgery, believing I was going to be a functional neurosurgeon, meaning that I was just going to, you know, treat epilepsy and work on computer brain interfaces. And then I got some exposure with spine, and I met this incredible spine surgeon, Jeff Henn. And Dr. Fessler was pretty cool too. Anyway, Jeff inspired me, and when I saw how well his patients did, like how well they did from the surgery, they got out of pain, their back pain went away. He was doing fusions, by the way, and artificial discs at the time, and I remember thinking, oh my gosh, this is kind of cool, you know, to see people happy with their results of their surgery. Because most neurosurgery patients, let's face it, they're dying, you know, brain tumors, trauma, they're dying. And it's just a matter of trying to give them the best chance of not dying. That's what you do. So when I saw just how effective spine surgery was for certain people to get them out of pain, and how happy they were after the surgery, I realized, man, this is actually one field of neurosurgery that's not so depressing, you know. Because that's the problem with neurosurgery, it is depressing. People dying of brain tumors, kids having brain tumors, you know, having to tell their parents their child is going to die. That's the worst thing in the world, you know. And I just couldn't see I was interested in pediatric neurosurgery. But anyway, I know I've kind of gone off on a tangent here, but in the end, here I am, and doing what I actually love to do, and guided by, I believe, God put me here and gave me a purpose and drove me here. And honestly, it wasn't because my professors encouraged me to do this. If anything, they discouraged me to do pain and spine. They wanted me to do, you know, brain tumors and aneurysms and things like that. But I never got that excited about it. I was more interested in, what are you doing? I'm still at the same place. I need you to go a little more north. That's fine. It's actually quite nice here in the transverse, whoa. So what I'm trying to do is get my probe exactly where it needs to be on the x-ray shot. And I'm moving it, and it's kind of sliding around because the bone that I'm on is this type of bone that it's not flat. It actually looks flat, but it's not flat. And because it's not flat, the metal probe tip slides on it. Shot? That's not bad. But I can feel the bone, so I know I'm in a safe place, and I just want to make sure I'm in an effective place. Remember, safe and effective? I think we got it. I'm good. All right. Blood pressure's good.
Yep, 100.
Put a little pressure there, please. Let me take care of that. You just put pressure. All right. Yeah. Move your hand. Shot. Okay. There we go. We're aiming for the next transverse process to superior facet junction. Right where the lateral border of that pedicle is. And let's take another picture. Move your hand. So that's at L4. You guys see right where the tip is? Show us, Jordan. Yeah, right there. And that's where the nerve is, right at that junction there. Go ahead, go ahead. So we're going to give her a little numbing medicine so it's not as uncomfortable for her when we burn. But we're basically burning the medial branch of the dorsal ramus. It's the pain nerve. We're burning it. That's what rhizotomy does. Typically, you use a burn. And the burn can be done with a radiofrequency probe, or it can be done with something more powerful. We're using the more powerful technique because the RFA probe, unfortunately, gives a weak burn, and patients are always coming back, getting more of them. And we don't want our patients coming back, not because we don't love our patients, we do, but we just don't want people having to keep coming back. I mean, it's always better if you can fix a problem once and for all. That's what my father taught me. Fix it once and for all, do it right the first time. And I try to teach my kids the same thing. You know, do it right the first time. So because I believe in that, I always try to fix things permanently the first time, not make people come back. All right, questions? Huh?
How many levels
We got the 5 and the 1 next.
As of now, no current questions.
Okay. I don't know if I can get the 5 and the 1 from here, but I'll try. Shot? It'll be amazing if I can, right, Louise? Why not, right? Shot? Oh, that's pretty damn good right there, huh? That's it. Go ahead.
We just got a question. This.
Yeah, if you're watching, feel free to ask questions. We've got about 5 minutes left. Type your questions up. I will answer them now, or I'll answer them face-to-face with you. When I do face-to-face, I have little spine models I can use to explain things. But I can do it either way. We're just about finished on this patient. I will tell you our next patient is, we're not going to be broadcasting her. She's having a carpal tunnel release. And we're going to actually be doing our first DPR for the knee pain. Shot? Uh-huh. So basically, she has bad knee pain, and she's supposed to get a knee replacement, but she doesn't want a knee replacement. Who does? Shot? And we said, well, let's try this Deuk plasma rhizotomy on your knee for your knee pain. Let's see if it works, right? I mean, if it doesn't work, it doesn't work, but you go get your knee replaced. But if it does work, then you don't have to have a knee replacement. And we think it's going to work. This is going to be history in the making today. Deuk plasma rhizotomy for arthritic knee in a patient who was recommended to have a knee replacement but doesn't want it, and she wants something less invasive. Of course, who doesn't? And because of that, we're going to be treating her with DPR. That'll be interesting to see if it works. She's our first guinea pig.
We have another question.
Shot. My gosh, I'm getting pretty good, huh there, Jordan? Right? I mean, I can't do any better than that. That's right on. Go ahead. Yes, we'll take the question.
This next one comes from Seriously, once more on YouTube. And they ask, can we see this procedure with the probe and the facet in real video instead of the x-ray video, so we can have some idea how this procedure looks in real life, in real time?
Well, thank you for asking for that. The reality is that you're seeing what I see. This is how we do it. We don't use the scope. Oh, you mean like seeing it from the ceiling? Like from the eye in the sky?
I believe that's what they're asking, yes.
Yeah, the problem is that with the eye in the sky view, you're not going to be able to see anything because the fluoro's in the way. Like, you know, that's, by the way, on that x-ray is the perfect spot for the L5-S1 nerve. It's right there. Yeah, unfortunately, you're not going to see anything, but I'll show you this. Move the fluoro out. Okay. So, can you guys see?
Yes, we can.
Here's the Deuk laser disc repair. 1 centimeter for the discs, and here's the DPR. Bring me the tape measure. 3 millimeters. 3 millimeters. So the whole procedure was done at 3 facet joints, and it's literally 3 millimeters. I think I might have 4 millimeters, but Band-Aid. Okay. All right, let's put 1 stitch, and we're done. But go ahead and type up your questions for me, and I'm going to put a stitch, and then we're going to wake her up, and she'll be going home. Yeah, no, she has the best anesthesiologist. Hey, everybody, great job. Folks, type up your questions, and I'll answer them for you in about 5 minutes or so. I'm just going to put a stitch and then a Band-Aid, and then we'll get her out of here. Thank you. Well, I appreciate that. Type up your questions. And Henry, you want to cut to one of our patients who had the DLDR done?
Copy that.
And I'm Dr. R. Deuk here at the Deuk Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year, of the new year. Now, you had the Deuk laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I'm a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall was pulling out a sofa bed thing. And I got so far with it, you know, we had company and I was opening up the bed, and all of a sudden I just could not move. I couldn't move. My husband had to practically carry me. So I was out of work for a week or so, and then at the chiropractor, and then gradually it got better, and I thought, well, that's fine. And I moved on. And then, you know, had a couple other times like that. One time I was drying my hair, getting ready for work with the blow dryer going like this with my hair, and all of a sudden, it's like I couldn't move. I couldn't move my arm down. I couldn't, I mean, it was that quick.
Yeah.
And just, I was out again for another week, laying in the bed and doing all that stuff. And then I thought I was fine, but I always, not always, but for many years now, probably at least those 30, I had lower back pain, where in the morning I couldn't bend over to brush my teeth. You know, that would really hurt.
Yes.
So I had that.
Do you have that pain now?
No, I don't think so.
It's gone.
The pain this morning, I was the first time in a long time I've gotten up first thing in the morning and was able to walk and not have that awful pain, because first thing in the mornings was the toughest.
I'm so happy for you. So how is this surgery going to help you in your life?
Well, hopefully once I can at least walk again. I was not able to barely walk with a walker. I was very active in my church and my community.
So you want to get active again?
And being in such pain now since July, and this is the new year, I'm anxious to get back to, you know, my life.
Yes, of course. Well, you had 3 herniated discs in your lower back, and you can see in the footage where we went into each of those 3 discs, and I used a laser to clean the tear, where you had a tear in the back of each of those discs called an annular tear, and the jelly from the center was stuck in the tear, holding it open, allowing more herniations to come out. So I got rid of the jelly that was in there using the laser, cleaned out the tear, and now your body will be able to heal that for the first time in 30 years. So I don't expect you to ever have that pain ever again.
Thank you.
You're welcome.
I am so thankful.
Well, you had faith and you found us.
Yes, I did.
You did what's right for your body, and I'm excited for you. So
I believe I did. I just kind of was led to you, and it just all went bing bang boom, and I didn't ask a whole lot of other people what they thought. I just did what I thought was I needed to do.
Good.
For me.
Is there anything you want to say to your fans out there?
I would recommend that if you do something to your back, that you take care of it early on. You take care of it right away. The longer you wait, the harder it is and the longer it takes.
It takes a toll on your life.
Oh, definitely. It has taken a toll on mine since this summer, for sure, where I have not been able to, sometimes not function at all, barely be able to sit in a chair and be comfortable without squirming, because I couldn't find that exact place where I didn't have pain. You know?
I don't see you squirming anymore.
No, I'm not squirming. I know. That's great. Sit here without pain.
Congratulations.
Thanks to you.
All right, have a blessed day.
Thank you. You do as well.
Dr. Deuk. I'm here with one of my patients and friends who I've known for years, and she has been suffering with back pain for, well, I'll let her tell you how long. And a week ago, she came and had the Deuk laser disc repair. She's here for a checkup, and I'll let her tell you how she's doing as well. So how long have you had your back pain for?
Started back in May last year, and I just couldn't get any relief from anyone. Finally, I asked you, and the rest is history. So this last week has been the best week of my life since May of 2022. So pain-free.
Excellent.
Yeah.
Now, I know it got bad last year, but did you have back pain on and off before that?
I did. I actually got thrown from a horse back in 2018 in Ireland. And that's what I think probably started it. I was having lower back pain, but never really did anything about it, just sort of lived with it.
Kind of modified your life, took
Yeah.
it easy, try to avoid things that aggravated the pain.
Exactly.
And now I know that you were suffering so badly before the surgery, and here you are with a smile on your face.
Oh yeah,
Yeah.
definitely.
Well, I'm so happy you're out of pain. You had the Deuk laser disc repair. You could actually see, we use a laser to clean the tear in the back of the disc where the pain comes from. The problem is most doctors don't know that's where the pain comes from, so they have no idea how to fix it. My years of doing endoscopic surgery taught me that that's exactly where the pain comes from. So it's a small little spot in the back of the disc. You fix that, the back pain goes away.
And it worked.
It's amazing.
It's like I told your wife, you're a miracle worker.
Oh, thank you very much. Is there anything you want to say to your fans out there?
I just highly recommend if you've had back pain in the past, don't live with it anymore. Call Dr. Deuk. He is the best.
Yeah, so many people's lives are just, quality of life is ruined by back pain.
It is, and not worth it. I'm ready to start traveling again, so.
Not too much too soon.
Not too soon, I know.
All right, very good, Jean. Great to see you.
Alrighty, thank you so much.
You're welcome.
I appreciate it.
Great to see you.
You too.
And I'm Dr. R. Deuk here at the Deuk Spine Institute. I'm smiling because I'm sitting with my first surgical patient of 2023. I don't know if you realize that, but you were the first one of this year,
Okay.
of the new year. Now, you had the Deuk laser disc repair done on your lower back because you had 3 bad discs, and we did that yesterday.
Yesterday, yes.
And here you are, one day later. How do you feel?
And I feel good. I feel good, and the pain that I've been suffering for months is gone. I mean, I was a little bit sore, but that's from the surgery itself.
Yeah.
But otherwise, I feel good. Feel good.
Now, you've had back pain too, on and off for 30 years. We were talking about that. Tell us about those episodes of back pain. What do they do to you?
The first one that I recall.
2, 1.
Okay, sorry for cutting short that really nice testimonial from one of our patients who underwent the Deuk laser disc repair. But we are going to take some questions and do some answering. And I know many of you who watched the surgery have been coming for weeks or months and have watched a lot of surgery. So you have asked me great questions over the time we've been together, and you may not have any questions. That's okay. For those of you who have not done one of these with us before, I will take your questions and answer them live. Just to help you understand what we did today, I'll use this model, which has screws and rods, but we didn't do this. We didn't put screws and rods. Our patient actually came to us with damage to 1, 2, 3, 4 discs in her lower back. She actually came to us with damage in 5 discs. I apologize. Counting from the bottom, L5-S1, L4-5, L3-4, L2-3. She also has a 1-2 disc, but it's not causing any symptoms. We left it alone. You know, about 90% of human beings over the age of 40 have at least one herniated disc. That means basically everybody on earth that's an adult has a herniated disc. A lot of kids have herniated discs as well. But the reality is not everybody has symptoms from those discs. And if you have a herniated disc, a degenerated disc, but no symptoms, we don't treat you. We don't recommend treatment at this time. Now, maybe in the future, it'll be different. But right now, I think asymptomatic herniated disc, degenerative disc, whatever, scoliosis, listhesis, stenosis, whatever it is, if it's not causing any symptoms at all, you should leave it alone. That's our philosophy at Deuk Spine. That said, part of the trick is figuring out where is the pain coming from then, if not all the discs that are herniated cause pain. Because disc herniations are the #1 cause for back pain. They are the #1 reason people have back pain. And typically in the average patient, it's 2.5 discs per person with back pain that has back pain coming from a herniated disc. it's coming from 2.5 discs on average. So the average patient will receive either 2 or 3 disc Deuk laser disc repair. If you only treat 1 disc, then you may say, oh my gosh, the surgery didn't work, but it actually worked on the 1 disc that we treated. If you have 3 discs that are causing pain and we only fix 1, then of course you're still going to have pain from the other 2 we didn't fix. So that's sometimes tough for patients to understand. And it's my job to figure out where their pain's coming from with their help. So one thing I always say, and you should remember, is MRIs never tell you where pain comes from. MRIs don't talk, okay? People do. So patients have to tell me where their pain's coming from. They have to take their finger and they got to point to it. And in her case, she pointed to 4 discs on her back. We tested them today with the discogram. All 4 were causing her typical back pain 10 out of 10. What was causing the pain is actually a tiny little tear in the back of the disc right there. And each disc had that tear. And that tear is the source of pain. And you can see there's inflammation going on there. That's actually my hot tamale, which I'm not going to eat, by the way, because I've touched it about 1,000 times. I'm sure it's got full of viruses. But it reminds me of my favorite candy to eat, which is a hot tamale. At the end of the surgery, we fixed those 4 discs, and one of them we did on both sides, the L5-S1. And then we actually went in and we treated facet joint pain, which is these things right here. These are your facet joints. Notice when the spine moves, it moves at 2 joints, the facet and the disc. Okay? All movement of the spine happens at the facet and the disc. Therefore, there are 2 joint possibilities for causing pain, the disc and the facet. It turns out in the lower back, the disc is responsible for about 80% of back pain. The facet is responsible for about 10% of back pain. And then, of course, the other 10% is your SI joint, piriformis muscle, coccyx, muscles. That's base fractures. Those are basically the other causes. All right, we'll take some questions.
Those next 2 are comments, and the first one being is from Daniel 1970M on YouTube. And they said, I am a hospital pharmacist of 28 years. I'm a hospital pharmacist of 28 years. I have seen the hospital care dramatically increase with nurse practitioners and nurse anesthetists. I see many more mistakes. It is frustrating.
Yes. Daniel, 1970.
M. Yeah, 1970 M.
1970 M. I don't know if you were born in 1970, but I was. Good year. So you are correct, and I appreciate you sharing that with the audience because it is frustrating. And even somebody like me who can see the problems with the care, the way it's delivered. By the way, I was the chief of staff at the hospital for 2 years in a row, voted in as chief of staff by the medical staff. So basically I was the top physician at the hospital for 2 years. And you know, I'll be honest with you, Daniel, I truly believe without any doubt in my mind, I'm 100% convinced of this, and I've seen it over and over again. It is literally due to reduced payments by the insurance companies for medical services. When hospitals are under tremendous financial pressure, because you got expenses which are relatively fixed and going up, actually, not going down, that's for sure. And then you've got reimbursement from payers like Medicare, but more importantly, not Medicare, because Medicare doesn't make any decisions. It's allowing Blue Cross Blue Shield to make the decisions. United Healthcare, Cigna, Aetna, Blue Cross, Humana, TRICARE, okay? All of these payers are not paying hospitals enough money anymore. They are reducing their payments. Because of that, hospitals' administration's job has become, how do we save money? All right, so their job is, how do we stay in business, right? And the way you stay in business is by getting more money, which they can't get from the insurance companies who are just stonewalling them, or reduce cost. So the natural path of least resistance for an administration is to reduce cost. They can't increase their reimbursements because the insurance companies say, screw you, we're no longer going to give you $100, we're going to give you $60. Take it or leave it. And if you don't take it, we're going to cut your contract, and then you're not going to have Blue Cross anymore. That is the threat that these hospitals are under. Doctors are under the same threat. And so we're forced to take less money, yet our costs are going up. So what's going to happen here? Well, you got to reduce your cost, which means you're going to reduce quality, period. There's no way around it. And that's what hospitals have been doing for the last 25 years. Our government has not done anything to stop it. It must be stopped by the government or the people. And the reason I talk to you people about it is I can't talk to the government. They won't listen to me. But I can talk to you. I can educate you. I can make you guys aware of what's happening. You go to your politicians. Politicians write laws. The key here, folks, is the insurance companies are corrupt. They are keeping all the money you're paying them as premiums. They're not paying the hospitals. They're not paying the doctors. They're keeping it, and their profits are soaring, okay? And you're not even seeing their real profits. They're hiding most of their real profits in subsidiary companies that service the insurance companies, and they don't have to report those profits to the public. They're private companies. So it's very, 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 very corrupt. And that's why we're seeing a decline in quality at the hospitals and all these issues. People fighting each other, you know, changing to alternative forms of treatment that are cheaper. I remember when I was a chief of staff, one of the issues that came up at my hospital was there's a procedure that could be done for patients with arteries that are closing off, okay, in their legs. And it's a stent that can be put in, very safe, very effective, but the stent costs like $5,000. Well, the insurance companies refused to pay for the stent, and the hospital then banned the procedure, and they made patients have open surgery, which is dangerous and life-threatening. They made the patients have open surgery because they would not allow the stent in the hospital because the insurance company wasn't paying the hospital enough money for the stent. That's crazy. It was a direct example of how the insurance companies are controlling how medical care is being delivered, and they're making patients have more dangerous, more invasive procedures than they should. They just want you to die and not get treatment. They don't want to pay any bills. So we have to face this evil. We have to address it. We have to fight it. Just like the TV show, the kids that fought the Stranger Things, okay? Stranger Things. I love the show. Forgot the name, but the concept's the same. I'm kind of old school, so Stranger Things is a little bit newer for me. I'm more of a Stephen King and It, where the kids, right, fuck the adults because the adults are so goddamn closed-minded. They're so scared to make change. Kids are used to change. Kids like change. Kids want change. Hell, when you're a kid, the one thing you want is change, right? You don't want to be under the control of your parents anymore. You want to be your own boss. So kids, Stephen King is brilliant. He knows how kids are. Kids want to change things and make it better, right? Adults just want to stay with what they've got. So Stephen King used a group of kids to fight evil. Well, sometimes adults got to act like kids. We need to act like kids, come together like kids do, put aside our differences, and fight the evil that's destroying our healthcare system, which is the insurance companies. Okay?
Nice comment comes from Seriously on YouTube, and they said, Doctor, if you need a guinea pig to do the demonstration DLDR procedure in Europe, I'm willing to be a volunteer.
Thank you. Yeah, I appreciate that. And guinea pig, when I say guinea pig, like I did earlier, our guinea pig today is actually a patient well known to us. She has a bad knee, arthritis like crazy in the knee. She's been told she needs a knee replacement. She's supposed to go get it done, but she doesn't want it. So we're going to go in there and burn 2 little pain nerves right around her knee and see if it takes the pain away. We expect it will. We're not the first ones to do a burning of the nerves to the knee, but it's typically done as what's called a radiofrequency ablation, or RFA. The problem is they don't last, so people keep coming back. We're going to try it with the Deuk plasma rhizotomy to see if it takes the pain away. And as far as guinea pigs go, I don't normally use patients as guinea pig, but this one is my mom. She's volunteering, my own mother, and I feel safe doing the procedure. So I would never normally use a patient as a guinea pig, so let's just clear that up. But my mom is here to get this procedure done. She's our frequent flyer. She's always getting all kinds of stuff done. She's in her 80s, and she's had a rough life, let's just put it that way, and she's got a lot of orthopedic issues, and you know, she's well aware of what we're doing. She believes in what we're doing, and She actually had the DPR done a couple of weeks ago, and her back pain is gone. The same one you just watched now, Deuk plasma rhizotomy, she had it on her back. She has no more back pain, so she wants it on her knee. And she's very demanding. It's hard to say no to mom, but she's a great person. And we won't be showing it because we're doing it in room 2, which doesn't have cameras. All right, next question.
Next question, this is a good one. This comes from Canes25 on YouTube, and they ask, when they make a movie about you, who will you choose to play you, sir?
You're funny, Haynes25. Well, Haynes25, I gotta be honest, I don't know. I don't even know that I deserve a movie. But what matters to me is that the truth gets out there and that people are able to get what they need to have a good quality life. Now, I've seen people suffer with back pain for 20, 30, 40 years. Heck, man, I had pain after my surgery for a week, and I was incapacitated. I couldn't even go to work. It's not right. It's not right when we can fix these people and it's not happening. So that's all I care about is I would like the name of the procedure to stay, the Deuk laser disc repair, so people remember the origin and the roots, not because of me necessarily, but because I want them not to be tricked into procedures that don't work. I want them to have the right procedure so they get it done and they have the best chance of getting well. That's what matters to me. But I appreciate it. I have been in touch with a movie producer, director, to do a expose on the spine world and the spinal industrial complex we talk about. He's watched some of our videos and he's very interested to help us. And I don't know where it's going to go, as I don't know where anything goes, but I put it in God's hands, and if something happens, great. If it doesn't, that's okay. We'll find another way. But ultimately, I think people need to know the truth. They need to know what's happening to them when they get fusions and stimulators and all these metal put in their spine that doesn't work. They need to know ahead of time it's not going to work most of the time, and that it's going to create more problems. They need to know there's a less invasive way. They need to know there's a better way that is available now. And that I owe the people. That is what I want to give people, knowledge. Then their choice will be their choice. People deserve to have a choice based on information. It's called informed consent, folks. It's something that we're taught as medical students, informed consent. You teach the patient about their options, let them choose what's best for them, as long as they're mentally capable, of course. Some people have a surrogate or somebody designated to make decisions for them. But in the end, whoever's making medical decisions should make them based on facts, not based on lies and deceit and deception and corruption, which is where our system is today. So that's my goal, is to clear up that corruption, to get rid of it, to blow away the smoke and mirrors, and for people to see the truth for what it is. And that's what I want help achieving.
And I believe, yep, that is it for questions.
All right, I hope you all enjoyed the broadcast. That was a long surgery. I don't even know what time it is.
It is
12,
yeah, almost 12:40.
almost 1 o'clock. So that was a long one.
Yeah.
But it went well. I think she'll do well. She'll be discharged in about 30 minutes, walking, and hopefully pain-free, and stay that way. So the next surgery is one we're not broadcasting. It's mom and her RFA, or not RFA, but Deuk plasma rhizotomy. And then I'm going to let Henry go home early today. He's got some stuff to do. So